Good morning, everybody. I'm Steve Pollack. I'm CEO at DentaQuest. DentaQuest is an organization that is focused on creating a shift in paradigm to revolutionizing oral health through a focus on prevention. I want to thank POLITICO for their help in organizing this morning. Definitely want to thank our panelists. I think you're going to enjoy hearing from them. And most of all, I want to thank you for joining us here for this important discussion and for those of you listening in. DentaQuest is a double bottom line company. What that means is that we have a business that's focused on improving oral health. We do that through a focus on prevention. That's through value-based care, through innovation. We really seek to get better outcomes at a lower cost for our customers. And there's 25 million people across the country that we serve. But we also believe that everybody deserves a fair shot at oral health. So we have an important social purpose, and we believe advocacy and policy play a really important role. And that's really why we're here today. We believe that getting more people involved in a discussion around oral health will help everybody get access to oral health. So I want to bring out Allison Corcoran to talk about an important research report that we just issued yesterday. It gives a 360-degree view of oral health in the United States, and I think it will tee us up for a great discussion. DentaQuest is a great organization. We have important values. If I had to summarize them in 2 words, I would say we're all in. And I invite all of you to be all in on our quest to make sure everybody gets a fair shot at oral health. Thank you. Allison?
Thanks very much, Steve, and good morning, everybody. In my work with the DentaQuest Partnership, I work with incredibly passionate change makers who are laser focused on transforming the oral health care system to enable better health through oral health. And at the DentaQuest Partnership, we do strategic grant making, we do research and analytics, as well as pursuing a variety of care improvement initiatives. In collaboration with our partners, many of whom are in the audience today, we are driving meaningful change at the local, state, and national levels. Over the years, our focus has been on systems change for oral health, advancing preventive care, as well as exploring new models of financing. Our research findings have informed our work and informed our grant making and our program development, which is one of the reasons we did this piece of research. Another reason is because I am the Chief Marketing Officer at DentaQuest. I have a keen interest in and experience with studies that explore public opinion, that understand consumer sentiment, and I believe, fundamentally, that there's always tremendous power in truly understanding the way people feel about a topic and their underlying beliefs. From that understanding, we can find those points of commonality that will help us develop a path forward to better outcomes. While we and others certainly have developed studies in the past that have looked at oral health and explored different stakeholders' perspectives, some of that data is old, and none of it has been truly comprehensive, all done at the same time. So as Steve mentioned, we identified an opportunity to sponsor a study that would provide a unique 360-degree view of the current state of oral health. We worked with a team at KRC Research to design a survey that spanned 5 critical stakeholder groups: dentists and patients, employers, because they pay for most of our oral health benefits, and Medicaid dental administrators. But also because we believe so firmly in the power of medical-dental integration, we also included physicians in the study. Having released the results yesterday, I'm happy to provide you a quick look at some of the high-level findings. So there is some bad news in the results, but there is reason for optimism as well. Our research confirmed that the current oral health system is failing millions of Americans, but that decay is reversible. We found remarkable consistency from patients, from dentists, from physicians, from Medicaid dental administrators, and from employers, not only on the problems surrounding oral health in the US, but we found agreement on the potential solutions. So let's take a look. Our failing oral health system is a major public health problem. We know this because 6 in 10 patients, dentists, physicians, and employers rate the health of Americans' oral health as very poor, poor, or fair. And 9 in 10 Medicaid directors rate the health of Americans as poor or fair. And not only is our oral health poor, the outlook for the future is currently far from bright. 8 in 10 physicians predict Americans' oral health will either stay the same or get worse. And 2 in 3 dentists, patients, and employers agree. For me, one of the most surprising findings is that 3 out of 4 patients, or 75% of those of us in the room, say that we have encountered barriers to getting dental care. 3 and 4. Those issues and barriers are cost of care, lack of insurance, or various access issues that, like locked doors, prevent people who don't have the key from walking in. So the inability to take time off work to go to the dentist, or lack of transportation, or for many Americans across the country, simply the scarcity of providers in their geographic area. And most Americans are concerned about their oral health. Half say oral health is their top health concern over heart, eye, digestive, and mental health. And the same is true for parents when asked about the concerns for their children's health. So there's also clear understanding of the important connection of oral health to overall health. And this is one of the exciting findings that I think is different than we would have seen a few years ago. As you can see, nearly everyone agrees that access to dental care is critical to improving not just oral health, but overall health. And more than 90% of patients and dentists, physicians and dentists, and 79% of patients recognize a tangible connection between oral health and overall health, including connections to diabetes, heart disease, healthy pregnancies, Alzheimer's, and so forth. At the same time, there is a significant level of confusion about the benefits that are available through public programs. Most Americans believe that Medicare at 80% and Medicaid at 78% should include dental benefits. This is a widespread, nonpartisan belief. But as we know, state-based Medicaid programs include benefits to varying degrees, and often only for children. A majority, 62% of patients, are either unsure or incorrectly believe that Medicare currently provides coverage for dental benefits, which it does not. For the 10,000 or so Americans who become eligible for Medicare every day, most experience a rather unpleasant surprise when they realize that despite having paid into Medicare all along, it does not offer dental benefits. These seniors have teeth and they vote. So, despite the negatives that I've shared, there is cause for optimism, and here's why. All the shareholder groups and stakeholder groups that we spoke to agree we can act now to help improve the overall system. Everyone agrees on the importance and the effectiveness of preventive approaches to improve oral health and overall health. So there is agreement on prevention first. Most dentists at 93%, physicians at 86%, and employers at 82% agree greater collaboration across medical and dental providers would improve patient care. Specifically, dentists and physicians agree that care collaboration can bring improved health outcomes, efficiencies, and reduce the cost of care. So there is agreement on the power and the future in medical-dental integration. Both patients and dentists see the value in taking care beyond the dental chair, expanding care to locations outside of dentist offices. including schools and community centers. So there's an agreement on improving access. And not only do most American adults believe oral health should be covered in Medicare and Medicaid, most Medicaid dental administrators agree that comprehensive dental coverage in public programs would help prevent disease related to untreated oral health issues at 68% and improve the health of their state populations overall. So there is agreement on the need for and the direction in adult public benefit. And finally, most patients, physicians, and employers agree that oral health benefits should prioritize healthy outcomes over the volume of services delivered. So new payment approaches based on value-based care is a point of agreement. These ideas aren't new to us. At DentaQuest, we've recognized these problems and have been working to raise awareness about the need to transform the system from the inside out for some time through that all-in approach Steve mentioned that we call preventistry. The survey confirms much of what we believe, and it is satisfying to see that while there is strong agreement on the issues and obstacles, there is a shared view on the solutions. The findings are encouraging because they indicate that working together, we really can improve the oral health of all. The system is indeed in a state of decay, but it's reversible. I encourage you to review the full survey report. It's a very interesting and accessible read, and there's a lot more in there. You can go to dentaquest.com/reversible decay and check it out. So thank you so much for your time this morning. Thank you for caring about oral health. And thank you for your continued advocacy on the behalf of the millions of Americans for whom the oral health system is currently failing. And I know that we are all going to learn and enjoy the upcoming panel.
Please welcome Politico's healthcare editor, Adrielle Bettelheim, and healthcare reporter for Politico Pro, Rachel Rubayan.
Yes, just about.
Well, good morning, everyone. It is an absolute delight to be here and to convene a discussion on a subject that sometimes flies a little bit beneath the radar of Washington's bigger healthcare debates. I want to thank Allison and Steve, and thank you again to DentaQuest for your support. And we just have a terrific panel that I want to get right to things. An estimated 74 million Americans lack access to basic dental care, and that's about twice as many people as the number of people without health insurance. And as some of you know, it's a very fragmented system where the traditional Medicare doesn't cover core dental benefits, but private Medicare Advantage plans do. Medicaid, it's up to the states. And if you have dental insurance, say through work, sometimes there's still very high out-of-pocket costs that cause people to delay or defer care. And untreated dental problems, as we all know, they can lead to chronic pain, they can lead to infections, they can lead to nutritional issues, but they also have a ripple effect, a bigger effect on the public health system. They factor into cardiovascular disease and diabetes that can cause complications during pregnancy. So we're trying to talk about costs and access and the bigger public health dimension. And Rachel, we have a terrific panel today to do that.
To help us dive into the issue, we have sitting next to Adrielle, Congresswoman Robin Kelly, a Democrat from Illinois. We have Rear Admiral Erica Schwartz, a Deputy Surgeon General at the Health and Human Services Department. We have Dr. Richard Mansky, the Chair of Dental Public Health at the University of Maryland School of Dentistry, and Dr. Julie Watts-McKee, the State Dental Director at Kentucky's Department for Public Health. I'll kick it off to Adriel for the first question.
I want to just welcome also the people who are not here but listening on the live feed. And if you want to join in the discussion on Twitter, please use the hashtag #PoliticoOralHealth. And that's Politico Oral Health, 3 words mashed together with a hashtag. So please join in. And we're going to leave time for a Q&A at the end so other people can get their oar in. But I want to start with the Congresswoman. You had success last year passing the Action for Dental Health Act, getting that through. Now you're working on expanding dental care for pregnant women in Medicaid. I'm just curious, when you look at the barriers to care, how much of this is an economic question, like how much Medicaid pays dentists? How much of it is kind of more of a cultural thing, connecting patients with providers?
I actually think it's a combination. I think it's economical, but I also think it's access. My district is urban, suburban, and rural. For those of you who know Chicago, I start at the Museum of Science and Industry, and then I go 100 miles south. So I say I have the city slickers, the suburbanites, and the farmers, because I have 1,200 farms in my district. And as you get more rural, there's not as much health care in the area, but also in some of my urban areas, there's not a lot of health care. And then also, some of our young kids, they don't see their parents going to the dentist or their older brother or sister, so it's not a tradition in their family until there's a terrible toothache and then you go to the emergency room. So I think it's a combination of access, culture, and economics.
So really you have the double deserts of care that they talk about, the inner cities and the rural areas.
Mm-hmm.
Now, Dr. Schwartz, in 2000, the Surgeon General's office released the first ever report on oral health. Your office is working on the second, slated to be released next year. Can you give us a preview?
Right. So for those of you who don't know, then Surgeon General Vice Admiral Satcher in 2000, he actually called the oral health situation a silent epidemic. His concern back then was that Americans were not aware of the epidemic that was occurring in the oral health community. So in 2000, he issued the first ever Surgeon General's report on oral health. It was entitled Oral Health in America. And that report, if you looked at it, really wanted to remind Americans regarding oral health is more than just healthy teeth. Oral health is about general health. It's about overall health. That was followed in 2003 with a call to action by the Office of the Surgeon General. And the call to action really focused on looking at a couple of things. The Surgeon General wanted to look at how do we actually start talking about the dialogue within the oral health community, making people, Americans, understand what it means to have proper oral health. The report also looked at how do we look at those programs that are effective and how do we actually replicate that throughout America. The report, the call to action, looked at how can we bring in these traditional and non-traditional stakeholders and start to collaborate within the oral health community, and how do we diversify the workforce? So in 2018, then Vice Admiral, our current Surgeon General, Vice Admiral Adams, recognized that we need to do more. We need to continue to have this conversation about oral health. So he commissioned a second oral health report. Now this report is really looking at where have we come since the 2000 report. What are the advances in oral health? What are the threats that are impacting the oral health community? What are the challenges impacting the oral health community? And where are we from a science-based perspective as it relates to oral health? There are various chapters in this oral health report. One of the chapters will cover oral health across the lifespan. One of the chapters will look at how do we look at innovations as it relates to oral health. Another chapter will look at addiction and mental health as it impacts oral health. And another chapter looks at oral health and its impact on the economy. So we are very excited that this report will be released in the latter part of 2020. And we're excited to continue the conversation about oral health in America. Thank you.
And Dr. Minsky, let's drill down into some of those topics a little bit. So nearly half of Medicare beneficiaries last year didn't visit the dentist. Over 15% have lost their natural teeth. Now, when you look at coverage, Medicare Advantage plan holders do have some dental coverage. So I'm wondering what some of the trends are you've seen in oral health for seniors and what some of the obstacles have been to a broader Medicare Part B benefit.
Well, there's been a lot said already. First, before I begin, I'd like to thank Politico and I'd like to thank DentaQuest. I think this is really an important day. It's important for oral health that we're having this discussion. One of the questions that you sort of asked before we got here is, how do we make a difference? Well, this is the way you begin making a difference, by having these kind of events and putting oral health forward and center. There's no question that oral health has a relationship with overall health, cardiovascular disease. But I would talk to my colleagues and tell them that oral health is important because oral health is important. It's innate. If anyone in this room has ever had a toothache, you know that oral health is important. If anyone in this room has ever had a dental infection, which could lead to sepsis and could lead to death, we know it's important. I've never understood why we separate out oral health the way we do when we don't do that with dermatology, ophthalmology, orthopedics. It's just part of health. It's part of medicine. And that's the way we ought to treat it. And for the elderly, it's especially important because what happens? We work, we're employed. Some of us who are employed have insurance, and one day we stop working. Hey, that's wonderful, I get to retire. But not only do I lose my income, I also lose my insurance. So I have even more difficulty paying for dental care at a time when some of the needs for dental care are increasing. And so I think this is the beginning part of it. There have been a number of efforts by a number of my colleagues. I see some of them in the audience here that have been working tirelessly trying to make the case about the need for an oral health coverage under Medicare.
Dr. McKee, you bring state officials' perspective to this. In Kentucky, your state released a strategic plan for oral health, I believe in 2017. What are the trends at the state level in using Medicaid to provide oral health for low-income adults? And what's working in your view? Where are things still falling short?
Well, that question could take the next 35 minutes and 45 seconds. Like Dr. Mansky, I do want to thank DentaQuest and Politico for bringing these two issues together. I access DentaQuest information every day professionally, and I access Politico.com information every hour because I'm a political junkie. But what's working with Medicaid, a lot of things are working and a lot of things are not working. And I can speak to my state and I can speak to national. Nationally, here's what's not working. States are decreasing their coverage of adults for Medicaid, and that's not good. Some states have reversed that because it got so expensive otherwise to do that. It was cheaper to cover them with that. We as public health dentistry are working toward that Medicare benefit because we have a whole lot more teeth than we did at 65 than we did in 1962 when this was first thought about. So what's going well in Kentucky is we do have dental benefits for adults. It is not the complete, comprehensive panel of services you see for our children, but it does what Medicaid is supposed to do, and that is to improve health and control disease. So that's good. One of the other things we're doing that's working very well in the state of Kentucky is a pregnant woman covered by Medicaid has full pediatric dental benefits so she can get good care during that will result in a heavier baby. We don't like fat babies, but we like heavier babies and more full-term babies to help with that. The things that are challenging us nationally is when a Medicaid person doesn't have dental benefits or somebody is totally uninsured, the impact of them presenting to emergency departments is incredible. It's very expensive, and guess what? ER docs, even though they're specialized, they don't do dentistry. So no dentistry gets done. It just gets the can gets kicked down the road. And as preventive dentists all over, we're looking to prevent that from happening in the future with better benefits. But it's dynamic. States come, states go. In Kentucky, the governor wanted to use dental benefits as to learn how to manage health insurance benefits by earning the dentistry. You had to do things to earn a filling or to earn an extraction, and to help them understand how to manage dental benefits with health benefits like we all have to do in the private sector. That has been delayed for a while. One thing that they are doing that's really good, I really like, and I think is on the cutting edge of how we take care of all of our body, is the new contracts for our managed care organizations that manage Medicaid patients include two big points that I like. Active patient management, patient navigation, to make sure one-on-one that people get what they need, including dental care. And another one is to address those social determinants of health that help us make healthy, that help us get healthy without looking like healthcare, like education and housing and heating and food security. So a lot of good's going on. I'm selfish. I want everybody to have access and paid for, and so they can have better cardiac health, so they can have better arthritis management, things like that.
It's an important point that with the Medicaid programs, the managed care, the private insurers are taking more and more of a hand in managing the benefits, including the dental benefit.
Mm-hmm.
Yeah. I want to turn the discussion now a little bit to the dental workforce. There's been a push in some areas to give dental hygienists and dental therapists bigger roles, initiating treatment without a dentist present or prescribing meds. And that's been something of a hot potato, and there's some barriers that exist. For the panel, how can the oral health workforce be expanded to improve access to care, particularly in the inner cities and the rural areas where there are these deserts?
Well, I'm the chair of the Congressional Black Caucus Health Brain Trust, and our main mission, of course, is to lessen healthcare disparities, but also to improve the diversity pipeline into healthcare. And that's something that we're very, very concerned about, because study after study has proven that you do better in healthcare when it's someone that looks like you, or at least understands your community and your reality. So that's very important to us. And we work with the Hispanic Caucus and the Asian American Caucus, Pacific American Caucus also on this issue. So that's something I think that we need to take a closer look at, and how do we get more people of color into the dentistry business, first of all. And I think that would be helpful. And because I do believe when you see it, you think you can be it also, and you think there's that opportunity. But then also healthcare clinics in various places, or where I am in one of my areas that is very low income, we have dental vans that go around in the neighborhood. So that gets some of my low income constituents into the dentistry, or getting their teeth fixed.
Mobile clinic.
Right, mobile clinics.
Dr. Mance, do you have an academic
yeah, sure.
school perspective?
Yeah, one of the reasons I was really happy about today's event, because it's really an opportunity for us to talk about innovations. Dental therapy is one answer. It's an answer. It's being tried. We'll get the data, we'll look at it and see how well it works. But why are we not rethinking dental education? Why are we still having dental education the same way today as we've been doing it for the last 30 years? Why aren't we looking at 3-year programs instead of 4-year programs? Why is it so heavily weighted for the sciences? I want to talk about diversity, and I'm glad you brought up pipelining, because if you allow me, when I wear my other hat, I'm the executive director of the National Museum of Dentistry, and there we do pipelining. And by the way, it was designated by Congress, thank you, as the National Dental Museum. Anyone here, if you haven't been there, please come. We'll give you a personal tour. It's wonderful. But we use that for pipelining. We're bringing in young children. One of the problems when educators do is they start thinking about diversity and pipelining when people are in college. It's way too late, because everybody's going after the small same pool. So the objective is to start it early, start it very early. And we're doing it K through 3. There's some follow-up activities at the school and middle school and high school. But if we really wanted to be effective, that's the way to go. But diversity also is, why do we just want pre-med students, pre-dent students with a science base? I would love someone who has an interest in education, someone who has an interest in philosophy, sociology, to want to apply to dental school. So I think we have an opportunity to rethink, are all of the sciences needed the way they're needed? All those prerequisites. And if we can just reduce the dental curriculum from 4 years to 3 years, what happens? We save 1 year's worth of tuition. We provide an additional opportunity for 1 additional year of income. That's a $150,000 flip. Why do we have so much trouble with access? The reason is dentistry is expensive. Why is dentistry expensive? Dentistry is expensive is because to become a dentist, it's expensive. The average student will graduate with a debt of about $250,000. If you want to go open up an office, it's another $250,000. On day one, you owe $500,000. Even if that person is well-intended, what do? They have to charge enough to service that debt. So there are some loan repayment programs, which are great, but those could be extended. And there are other things that can be done. There can be partnerships. The dental therapy is one. But, you know, let's say in an inner city, you mentioned before that you have both city and rural. In an inner city, there's vacant buildings. Why couldn't the city say, I'm going to go and buy this building. I'm going to do the leaseholds. We're going to buy used dental equipment and set up an office inexpensively, and we're going to identify someone who wants to go in there. Then that person can charge lower costs. So it's really a combined effort. There isn't just one specific answer.
If I could just jump in,
Sure.
My husband is an anesthesiologist, and he was a sociology major in college. So he,
Well, and I'm glad, because I wish we'd get more.
so he's smooth at the bedside.
But you know, we kid about that, but there's value in that. It's a more diverse workforce in lots of different ways.
Absolutely.
And let's take a look a little bit at kind of expanding the insurance coverage options, big topic in this. The House and the Senate's Medicare for All bills include a dental health benefit. Speaker Nancy Pelosi released her drug plan last week that envisions potentially using some of those savings to add in a dental benefit. So I'm curious, either for the Congresswoman, Dr. Mansky, how you could set parameters for what that coverage would look like if it was expanded into Medicare, how robust it would be.
Do you want to go?
Well, for me, definitely preventive care. I mean, I think you have to start young, and preventive care, getting people in the habit of going to the dentist every 6 months. Some of my colleagues, one of my colleagues has a bill, I think it's, if I say it right, ears, eyes, and ears, eyes, and
Vision.
teeth, or whatever, vision, so that your dentistry is paid for, your glasses and your hearing aids. I can't believe those aren't paid for. And there's another colleague has something for seniors that their dentistry gets paid. Now, I think, you know, we have to look at our budget. Your budget is, to me, your moral thoughts and what we need to do. And this is something we definitely need to look at and do as much as we can do. I mean, once you leave work, if you don't have insurance, dentistry is not cheap, but I think, and we need to do everything we can do to prevent people from going to the emergency room, because then we're spending even more money. So I do think we need to look at it from the preventative approach.
And sort of, Dr. Schwartz, Dr. McKee, how do you you talk about preventative care, Congresswoman, how do you incentivize people to go to the dentist? They have this coverage. How do you ensure they go to the dentist? And are dental schools playing a role here?
I don't know if dental schools play a role, but in Kentucky, parents are incentivized to take their children to the dentist. What breaks my heart is the incentive to get dental care paid for is not incentive enough. I feel like that when we include dental benefits for our 65 plus, I think they're aware enough that that's incentive enough to do it. Another thing is really not an incentive, but it's a trigger. And I would like for the medical dental collaboration to work together, that when somebody of any age goes to their physician on anything, but especially for preventive or follow-up care, they make sure that they've seen a dentist, because that impacts so much. But we do incentivize our parents in Medicaid with gas cards, but I don't know what else it would take. I'm sorry, it's not, that coverage is not enough.
Why haven't, I mean, it seems like, you know, this could be something that could be rolled into Medicare Part B, or you could have dental discount cards like they used to do with drugs before they did Medicare Part D, is it a cost issue where you just can't sell that?
Yes, so there's two parts to this. One is, you asked a question about how do you motivate people to go. I think one of the things we haven't done well is we have not had a public campaign, a sufficient public campaign to talk about how important oral health is. And that should be a national effort. We just, I think, need to let people know that you need to see the dentist, you need to take care of your teeth, and it's important. The second part of that is, I think it's an opportunity for us to learn from Medicaid. So if I were to show any person in this room a Medicaid plan on paper, what's covered, you would buy that in a heartbeat. The problem is, it doesn't behave the way typical insurance behaves. In the private insurance market, what they do is they'll figure out how much dentistry we will have to pay for, how many eligibles there'll be, and then they calculate a premium. The problem with Medicaid is there's a fixed budget, and you alluded to that. There's a budget. And then within that budget, everything has to be paid for. So if you have an unlimited number of people who are eligible, and you have an unlimited number of services that are then to be provided, what's the only remaining factor that can be adjusted to make that budget work? That's the price per procedure, the fees that we're going to reimburse practitioners for. And what do? We drive practitioners out of the marketplace. And it makes sense. It's a rational decision for them. So, you know, we sort of achieve through that kind of rationing the way to control the budget. We have an opportunity to innovate these kind of programs by setting up tiers of coverage. We talk about emergency departments. How do we keep people away from emergency departments, inappropriate use of emergency departments? Because I actually do believe there are appropriate uses of an emergency department for dental. After hours, on weekends, evenings. I mean, if anyone here were to call up their physician office, you're going to get a recording, and it's going to say, if this is an emergency, go to the emergency room. That emergency could be 103 fever. That normally wouldn't be what we think of as an emergency. So I think dentistry is appropriate there. But we have an opportunity where we could tier the kinds of procedures, and we have to have that hard discussion, that hard debate amongst ourselves, and make the decision, what are the things we know we need to cover? Well, we need to cover treatment for pain and infection. We need to cover for, you know, maybe there's another tier for restorative care. And then make some decisions about how we allocate those budgets instead of by just rationing it out through the lack of access and the non-availability of having practitioners because they're driven out of the marketplace.
And I just want to say one thing, just to emphasize what you just said, the incentive piece, I think that if we can continue to remind Americans that oral health is not just healthy teeth, oral health is overall health, and to incentivize them to say, when you're taking care of your teeth, you're taking care of your entire body. So I think we can't foot stomp that enough from the Office of the Surgeon General that, you know, and that's what the upcoming report is going to remind folks, is that it's not just limited to just, oh, you got to take care of your teeth. You've got to take care of your teeth because it's connected to your entire body, right?
And that supports Dr. Mainsky's point of the campaign for information.
Right.
To make people value what's going on. One of the big differences, and yeah, if you looked at the Medicaid coverage, it's deep and it's rich, especially for pediatric patients. But one of the big differences that we see is with that, you don't have when you are covered by Medicaid, even as an adult, you don't have a yearly limit for benefits. But when you have dental insurance through a private sector, you have a yearly limit for benefits. I started practicing when dinosaurs walked the earth in 1983. And the yearly benefit was $1,000. Well, that doesn't even cover a crown now. And now, many of the plans are still at $1,000 or maybe $1,300. And that makes dentistry, once again, an optional part of healthcare that should not be.
It seems like whenever there's a talk about, you know, system reform like this, especially in the context of a Washington debate, you begin to come up with new models for payment and delivery. For the panel, could you foresee value-based purchasing in dentistry? Could you see dental care eventually being rolled into a primary care setting?
I would like dental to be rolled into a primary care center. I think it would be helpful if some of the urgent care centers were to include dental. As far as value-based payments, you know, it's interesting. So much of what we talk about, especially in this town, in D.C., is all driven by what happens at hospitals. But healthcare is not monolithic. You know, there's hospital-based care, there's outpatient-based care, there's pharmaceutical companies, and then there's emergency departments. I would make the argument that emergency departments are a public good, you know, and it should be funded no differently than the way we fund fire, police, the ambulance. In fact, I would ask, where does that line drawn when the ambulance drops a patient off? Is that line right at that door? Maybe that line should be moved back in closer to the, you know, inside the hospital. Maybe we ought to be funding, you know, the emergency departments as a public good and funding it, you know, nationally. You know, hospital-based care is driving so many of the decisions, but it has nothing to do with the way outpatient care is being delivered. And there is no one simple answer. That's my concern about Medicare for All. There's no one answer. I remember when I was in high school and I was first learning about how to take multiple choice tests. And the question was, you know, if the answer is never or always, it's probably wrong. So I think, you know, there's an approach that, you know, that those things can be helpful, but I think we can learn from that.
And some of my community health centers, they have both dentistry and I know we're not here for mental health, but they also have mental health also, because that's the other healthcare that kind of gets put separately, like dental, and they have both, but then some have neither one.
Yeah, I wanted to put a plug in to your point, Congressman, regarding HRSA's support of the community health centers, and those are combining both medical and dentistry in one setting.
A reminder to our audience, in just a few minutes we'll be turning to your questions. We're going to have someone, maybe a couple of people with microphones, so please get ready. And if you're following us on the live stream, please join us on Twitter using that hashtag Politico Oral Health, all mashed together. I was taken by some of these stories about dental tourism. People going to Costa Rica, to other countries where there's U.S.-trained dentists in many cases providing service at a fraction of the cost. What are we to make of this? Is this like a failing of the U.S. system, or is this just a logical evolution of a market that knows no political boundaries?
Well, I think it touches a little bit on what I was saying before, about so much of what we do and talk about in healthcare is driven by what happens in hospitals. And hospitals are expensive. And I think we need to rethink how we look at hospitals anyways. I mean, hospitals behave like a utility, and we should treat them the way we treat utilities. But, you know, when you think about hospitals, there's a care component, but there's also a hospitality component. You know, some of these things, when you talk about value-based payments, what are we asking patients about? How were you treated? You know, how did you feel about it? That's all part of the hospitality part of it. And I think separating that out, separating out the two components, treating the actual hospital itself as a utility, and then having set aside plans for the kinds of things that people care about how they're treated, how long they have to wait, what happens afterwards, the follow-up. That's more of a hospitality function. I really think, again, given that we're in D.C., there are so many opportunities for innovation. And one of the things that I've learned about dentistry is that, and you mentioned it before because, you know, back before the ACA, you know, there were 50, 60 million people not covered by health insurance, but there were 150 million not covered by dental. You know, now the numbers have changed a little bit, but that means there are so many opportunities in oral health and dentistry to experiment, to learn, because everything we learn in dentistry is applicable to what happens in office-based medical care, and to every part of healthcare other than hospital-based care.
And Dr. Schwartz, is your report looking at how to integrate some of that, and what have you found in some of that preliminary research?
So we don't want to open the curtain too far with the report, but more to follow, but absolutely we will be touching on that in the report.
I also think that we're at a pivotal time in Congress because there are 5 dentists that are congressmen. That's what, and I'm Democrat, they're all Republican, but that's what they helped me get my bill passed. So I think this is a good time to enlist them in some of the things that you think is important to do.
So you warm my heart. The idea of a Democrat working with a Republican.
I do it all the time.
Because these healthcare battles, they have been wars. I've called them healthcare wars. In fact, Congresswoman, I would say to Speaker Pelosi, Senator McConnell, President Trump, if you give me a half an hour, I have a plan that will be bipartisan, will get you a supermajority in both the Senate and House. I hope you're listening. Invite me in. Happy to share it.
You can make that happen.
Well, we want to,
I'll tell them.
We want to bring the audience into the discussion. We have about 10 minutes for Q&A. Please raise your hand. Stand up. Let the folks with the mic find you. And let's start with the lady over here and then right behind her. Hi.
Hi, great panel and wonderful forum. I'm Ann Greiner from the Patient-Centered Primary Care Collaborative. So you might know where my question's going. I appreciated Allison's remarks and yours about this integration of oral health and medical care. What do you think are the most important strategies to pursue to really have that team-based approach so that we can take care of the whole person, put the mouth back in the body?
Dr. Minke?
I'll start. I hope everybody else has a contribution. What's the best? Just like everything else, there's a list of bests. But one of the things that we're seeing just as a rumbling across the country, which I think is an incredible idea, is to have a special category for dental hygienists that are called primary care dental hygienists. And these dental hygienists on their daily work would not work in a dentist office. They would work in an office of an endocrinologist, of a cardiologist, of a pediatrician, to make sure that the dental care is being addressed at the site of primary care. That integrates both the medical part and the dental part, which needs to come together more. Then that hygienist can see if another need needs to be met outside, cleaning them up, giving them oral health education, that the proper referrals are made for dental care, for oral surgery care, or to bump up this patient on the physician, either specialty or generalist, that they work for to make sure that their needs are more quickly addressed. I think that can help integrate that medical dental to make sure that oral health is part of overall health, just not teeth.
Right, and just to elaborate on that a little bit more, having oral health educators embedded in traditional medical clinics would be something that we would love from the Office of the Surgeon General to see pursued.
So, and I agree. I think that's absolutely correct. One of the things I've been advocating for quite some time is I think we need some more dual degree programs. And I think we need some programs where students can go to dental school and get an DDS and an MD at the same time. But again, we need to rethink the curriculum, and I think that's an important opportunity. Because there won't be a large demand for those combined degrees, but they're definitely needed. And placing dentists in the urgent care centers in addition to FQHCs would be a good idea too. And I think for those urgent care centers, if they haven't thought about it, start thinking about it. It could be a profit center for you. I think it's to your advantage and it's to the community's advantage.
I mean, I'm a physician, you two are dentists, correct? If you looked at our curriculum going through medical school and dental school, it's very similar, and yet we aren't having that conversation as physician and dentist.
Right, I agree with Dr. Mansky's point about the dual-degreed health professional. And another reason for that, to me, is our population, because we're aging and some other things that we like to do, like get fat, is that the patient population is much more medically compromised than it's ever been. And so you need to have that information about, well, if I use this particular anesthetic, what's that going to do to the cardiovascular thing? If I put them on, or I want to do an implant, but they've got osteoporosis, you know, all that comes together. And with a dual degree, we can, once again, reduce the time that care happens.
So it's sort of interesting, because we're talking about older adults, we're talking about comorbidities and complicated medical conditions that someone might have. Again, it's an opportunity to rethink education, because aging in of itself is not the issue. It's the comorbidities that go along with some people who are aging that we need to deal with. And for that population, having the combined DDS-MD degree would be really helpful. And I agree with you. Yeah. It's not that difficult. The dental students, they could take step 1, step 2.
Absolutely.
Let them do it. Let them go on rounds. I think it would be fun. You know, and then maybe at the same time, we can, you know, for those students, we expand it. For other students, we cut it back. Let's start thinking about education differently in ways to better meet the needs of our, you know, of our citizens.
Let's jump in and take one more question right there in the center table.
Yeah.
Hi, I'm Cindy Pearson from Raising Women's Voices for the Healthcare We Need. There hasn't been much mention of women, so I wanted to give all 4 of you an opportunity and ask you if you could just say quickly, what's one change you would make that you think would benefit women most?
Specifically in dentistry?
Yeah.
Oh, wow.
How about, can I, let me jump in for a second. I'm gonna flip it. I'm gonna go back to the museum because we just put in the new exhibit called The Changing Faces of Dentistry. When we started off in our profession, it was all white male. Now it's much more diverse, and our students are now 50% women. So, you know, I think we've already made advances. And there are women who are going to be dentists. There are women who are dentists. Half of our student population are women. They will advocate for women's health. They will do the things that you're looking for. So I think in that sense, dentistry's made tremendous progress.
And I'm working very diligently. I've been working for the last 3 years, but I have the big bill on maternal mortality and morbidity. And so making sure that women are as healthy as possible when they have their baby, and that health continues on through 1 full year, because right now, if you're on Medicaid, it's just 2 months. We wanted to continue 1 full year because 70% of women that get sick, it's after 2 months. So that's what we're working very, very hard on now.
And the Office of the Surgeon General, we collaborate with the Office of Women's Health on a daily basis, and not only with maternal morbidity and mortality, but as he takes on the bully pulpit as the Surgeon General, he often makes sure that he is touting and talking about women's health issues to include oral health.
That debate is, of course, also at the state level as they reshape their own Medicaid eligibilities and extending this 1 year postpartum.
And some states have
it's a very
done well, some states no.
More questions from around the room. We have 2 in the back, sort of right way in the back.
I just had one question around covering dental health under Medicare. I've heard that dentists and the Dental Association is not necessarily on board with that because they prefer the higher reimbursement rates of either Medicare Advantage or a separate dental health plan. And so how, just like as a policy question or in DC, how do you go and make that movement when you don't even have consensus in the dental industry? Or whoever wants to take it.
I'll speak for my colleagues.
We do a lot. We don't have consensus.
Yeah,
we just have to keep.
It's difficult. Look, my colleagues' behavior is rational. It makes sense. And I think there's an opportunity to find that sweet spot where they will be encouraged to want to participate. But we need to put together plans. And I think, you know, from the efforts that I have seen, I kind of see my colleague sitting there, he knows that we have made great strides in reaching out to the American Dental Association and working with our colleagues to find a plan that would both work financially and both be comfortable for existing practitioners. So I think we've actually made some progress. I think the American Dental Association has actually come a long way. One thing to remember is that truth is dentistry works for most people in this country, but dentistry is expensive, and we're just trying to figure out how do we make dentistry not only work for most people, how do we make dentistry work for everyone?
About 3 minutes left. Let's take one more.
That guy right there.
Yeah.
Hi, my name's Lawless Barrientos. I work with DentaQuest. I had a question for the doctor concerning dentists in general. What I've noticed is access is a huge problem in most of our states. Why is it that most dentists only work 32 hours a week or Monday through Thursday, whereas a lot of our physicians work Fridays and through the weekends. I was just curious as far as the history of that's concerned, and why is that the case?
Because they can? You want to go first?
Well, one of the reasons, honestly, that dentists may work less hours a week is dentistry is physically hard. It's physically difficult. Ask any dentist and they'll complain about their neck and their back and their hands after several years of that. So that's part of it. Otherwise, I don't really know. Anybody else?
I'm a physician, sorry. I'll defer to I work hard.
I actually don't know that those are the hours. The colleagues that I have, they tell me about their long days and the number of patients they have. I would actually like to see the data. But it's, if they're working efficiently, fine. I don't think that's the problem. There isn't, you bring up an interesting point. So one of the things that bothers me is that if I'm as a dentist, I'm out there in practice, and someone comes to my office and I want to lower their fee for them as an individual, they're paying cash, because most of my colleagues really want to help out. There's a problem. If they do it one time, they sort of get away with it. But if they do it over and over and over again, the next time that they submit a claim for insurance, when they sign that little line at the bottom of the form, they're basically then saying, this is my usual and customary fee, which it's not. It's a problem. So we need reform. We need some flexibility. If you want my colleagues out there to be able to be a little bit more generous, which I think they really want to do, we have to provide them the ability to do that without affecting all of their other claims and payments. It's just the way the insurance market works. And for any of you in here who've ever had to fill out an insurance claim, you know that when you sign that bottom line, you're saying, this is the usual customary fee that I charge every patient, whether they're paying cash or it's insurance.
And I'm just going to have to jump in real quick. Unfortunately, we're out of time, such a fast-moving, long conversation that we could continue to have on this, but we learned a lot about coverage and access issues and potential ways to integrate medical and dental health care. So I wanted to thank our panelists again, Congresswoman Kelly, Dr. Schwartz, Dr. Mansky, Dr. McKee, and thanks again to Dental Quest and for you all for being here early on a Tuesday morning? Tuesday morning.
Still Tuesday. Thank you all.
Thank you.
I have a PhD, so I could have been in sync.